Hello everyone, this is Chadi from SIF 2023. I'm really privileged today to be with Dr. Kush Agarwal. We're going to talk about vascular access. Now everybody driven toward radial access, but we shouldn't neglect the femoral. So when do we pick and what's the pros and cons?
Shadi, thank you so much for a chance to talk. I hope that the listeners can get something out of this brief talk.
Absolutely.
What I would say is that I'm a community interventional cardiologist here in Scottsdale, and we do about 250 or so PCIs a year, so we're fairly busy. And of course, the demands on the community interventionalist include a time pressurized existence.
Yes.
And so not only is, of course, in the vast majority of cases, radial safer, but also more time efficient.
Yes.
And our teams are now fluent in radial access, especially during STEMI. And so in the non-shock hemodynamically stable STEMI patient, we are radial pretty much every time.
Yeah.
I wanted to emphasize that there's still a very important role for femoral access. However, because not at the very least is to preserve that skill set, but of course to maintain the need for shock, mechanical circulatory support, in addition to preservation of radial limb grafts for potential coronary bypass grafting, in addition to multiple access sites. For instance, if you're doing CTO PCI, so it's important to have the absolute best practices that you can employ as a practitioner for safe femoral access.
So you mentioned something about preserving the radial for graft. So
Yes.
Are you telling us that the radial axis, if I access it, I'm compromising the graft?
No. So if you look at just real world registries, our practice these days for radial access is not harming the radial artery. Most of the time it's right radial access for coronary angiography, and because we are using slender sheets. In our practice, we're using only 5 French sheets for the diagnostic portion, and of course, we're using slender catheters and with vasoactive medications, verapamil, nitroglycerin, etc., and of course a heparin cocktail. We are very much diminishing radial artery thrombosis. It's important to mention that about a year ago there was interesting work published in China called the RESTORE trial, looking at about 1,500 patients who received Xarelto, rivaroxaban 10 milligrams for 1 week post radial artery cath, and only 1 week.
Just a trial to take
see, and what they found was that while there was no increased bleeding, there was at 1 month a significant decrease in radial artery occlusion, on the order of 3-fold. And that's believed to be a restoration of radial artery recanalization. So it's interesting to say that could help broker safety between the best practice, which is radial artery catheterization, and preservation of the radial limb graft for our surgical colleagues.
Yeah, and also for re-access in the future if needed.
Absolutely, absolutely. And I do think that we are underutilizing distal transradial because of the technical challenges, in addition to ulnar catheterization in an ulnar dominant hand. So I think that those are skills that ought to be developed too in our future trainees.
Right. So what's your usual cocktail for the
and it's a little bit modified based on the patient's bradycardia and hemodynamics. But if you had to paint with a broad stroke, I would say we use 200 to 300 micrograms of nitroglycerin intraarterial, in addition to 2.5 milligrams of verapamil intraarterial. And then once we know that we can cannulate the coronary arteries from a radial approach, then we'll give IV heparin, and usually it's between the order of 4,000 to 6,000 units, international units.
And this is it's interesting you mentioned that, because there's some people would like to know the anatomy, if you can get over the arch, engage better, not challenging before they give the heparin, not to compromise increased risk of access for femoral.
Right, and I would say in my experience, one case out of 15 to 20, you'll find that there's such an intense loop in the subclavian and brachial anatomy that you've got to rely on whatever tricks you have with the JR4 catheter and a woolly wire. However, should not dissuade the operator from using radial artery access as the primary, because we have 50, 60, 70 centimeter long radial sheets that can then obviate that tortuosity and still allow you proper, torquing in the coronaries.
Absolutely.
So I still think that there's a value to struggling a little bit, but to perfecting the radial skill set.
So your message is don't give up. If you're going radial, don't give up so quickly.
Yes.
Learn some techniques, as you mentioned.
Absolutely.
From Dr. Agarwal. And as well as there's a lot of resources online that can help you over the loop, spasm, radial loop. I mean, these things shouldn't persuade you to go directly give up, go to femoral.
Right. And if you do go femoral, which should happen and will happen, every time should be ultrasound guided, and every time should have a micropuncture access.
Yes.
So,
Dr. Agarwal, thanks so much for being with us.
Thank you.
Please watch these videos and others on SIF Conversation. This is Alraies from Scottsdale. Thanks so much for being with us.
Thank you.